Hello, everyone. Welcome to the webinar series for the Autism Intervention Research Network for Physical Health, the AIRP. My name is Keisha Rosenau, and I'm a developmental researcher at UCLA and a project scientist on the AIRP. I want to thank all of you for joining us today. Before we begin, I would like to address a few logistical details. I will provide a brief introduction for our speaker, and will also reserve time to answer questions at the end of the presentation. Because of the number of participants, your audio will be muted throughout the call. However, you can submit questions at any point during the presentations via the chat box on your webinar console. The entire webinar is being recorded and will be available on the AARP website, which is airpnetwork.ucla.edu. There will also be a short evaluation survey at the close of the webinar. We invite you to provide feedback on this webinar and also to provide suggestions for future webinars, as this is the first of many monthly webinars hosted by the AARP. In the interest of time, let's get started. It is my honor to introduce Jessica Rast. Jessica is a researcher at the A.J. Drexel Autism Institute at Drexel University and the first author of the recently published National Autism Indicators Report on Health and Healthcare. Please join me in welcoming Jessica Rast.
Thank you so much. Thank you everyone for being here. I'm really looking forward to presenting our findings today. I'm going to talk to you today about health and healthcare and autistic children and adults. I want to start first with just a note on language. So throughout this presentation, I try to use the term autistic when talking about the people who are presented in this data today. I also sometimes will use the term ASD or on the autism spectrum. I do try to show preference for the term autistic, and I apologize if and when I mess up on that, but I want to point everyone to this current commentary on language that was recently published in Autism in Adulthood. It does a great job of explaining why I'm paying attention to this and why I think other people should be as well. It explains the role of language in how we communicate with people and how language is connected to ableism or discrimination against people who are differently abled. All right, so I'm going to start by telling you a little bit about where I came from. I work in the Life Course Outcomes Research Program at the H.J. Drexel Autism Institute. There we take a public health approach to autism. That means that we aim to understand the experiences and improve the outcomes of people on a population level. We also take a life course science approach to our work, and in relation to health, what that means is that health and healthcare needs change across the life course. A person's experiences and their health earlier in life have an influence on their later health outcomes, and a person may be more vulnerable to developing health conditions or experiences and disruptions in their healthcare at certain critical points in their life, including the transition to adult healthcare. Furthermore, health is influenced by a complex mix of biological, social, and societal factors, and those also change across the life course. So we like to use this visual metaphor to talk about the work that we do. This is a car's dashboard, although there's not much dashboard to speak of here. This is an old Model T. So people drove these cars, probably had fun doing it, but they didn't have any measure of how fast they were going, how much gas they had, or how far they had come. Our current understanding of outcomes of autistic people, particularly our adults, is not unlike the dashboard of a Model T. We have very little data to help us plan and monitor the outcomes of autistic adults. But in the US, we do spend billions of dollars to serve autistic people. In a report from 2013 from the Interagency Autism Coordinating Committee, they showed that between 2008 and 2012, federal and private funders in the US spent $1.5 billion on autism research, but we know little about what these expenditures buy us and if they're moving the needles on quality of life in autistic people. Enter a more modern dashboard into our metaphor. So our work at the Life Course Outcomes Research Program attempts to provide national level indicators to understand how people are doing, what services they need or what they're using, what factors are influencing how their lives turn out, and what current strategies are being used and how they're working. These are the types of questions that we focus on because they're useful and practical, and they have the power to inform real-world decision-making in government and service agencies. We are aiming to build a dashboard like this of indicators across outcomes and across ages. So how do we do this? We're building these gauges largely using existing national data, which helps us capitalize on money that's already been spent. We create information products that are accessible, understandable, and impactful. And we identify gaps in data between what is available and what we see as needed. Okay, so now that I've shared a little bit about where I'm coming from, I'll share with you some findings from our most recent report. So these are related to health and healthcare. And this is part of our ongoing attempt to build these indicators, particularly around health and healthcare and how things are turning out across the life course. So why focus on health? We focus on health here because health is an integral part of quality of life. When you have good health, you might not be thinking much about it, but when your health is poor, it impacts all aspects of your life. So then why focus on healthcare? Health and healthcare are very intricately related. Healthcare impacts health by dictating the types of services a person can receive and when and where they receive care. And in much the same way, health policies and insurance impact healthcare. And we also know that health services and reimbursement patterns are not optimized for comprehensive care. There's also been a recent national push to focus on health and autistic people. So a good example is this HRSA reinvestment in the ARP Research Network, which is the venue through which we're presenting these findings today. The Autism Cares Act in 2019 requires a report that be submitted to Congress on the health and well-being of autistic people. The Interagency Autism Coordinating Committee, which is part of the U.S. Department of Health and Human Services, convened a subcommittee to address the health needs of autistic people. And there's been a surge in national research attention on health, starting to identify this as an important issue. So need for this report also comes from the knowledge that autistic people often have trouble accessing the care that they need. So we know that they often have complex health needs. They may use care more often and have higher healthcare costs than their peers. They may have more emergency department visits and inpatient hospitalizations. And then even when they do access care, we see high reports of unmet healthcare needs. And then there's also a few contextual points that I want to make. Social and political factors influence health and services. So that might include access to services and things like healthcare policies. It also includes race and ethnicity, which we know influence health and health services. Healthcare needs and health change across the life course, and early experiences in health and healthcare impact throughout the life course. And then certain parts of healthcare are more complex than others, and we know that one of those points is the changes between pediatric and adult healthcare. So with all this in mind, the purpose of this report is to catalog health and healthcare and autistic people across the lifespan, highlight the inadequacies in the current care systems, support recommendations for improvements in health and healthcare. All right, so then we will cover the following topics to this end. We have 5 chapters of results. I'm going to go over those. We have overall health, health services, medication, insurance, and accessing services. All right, and then after I go over those, I want to spend some time highlighting a few findings that span some of these topical areas, and I think that they deserve some further explanation. So one of those is healthcare transition, primary care gaps, and then racial and ethnic disparities. All right, and then I also briefly want to mention that we use these 4 sources of data for this report, and they each represent a different population, so I think it's just important to note what they are. So the first 2 are national surveys conducted by the US government, and they capture the health and healthcare of a national sample of children. The third one is a sample of inpatient hospitalizations in the US from the year 2017. So this captures almost all hospitalizations, but excludes long-term rehabilitation facilities. And then the last source is a little different. So the last source was, we compiled previously published findings from Kaiser Permanente, Northern California. Kaiser is a healthcare system that covers roughly 4 million people in the greater Northern California area. We ended up including this data because there's really a limited amount of national level data on adults, what their health is like and what their healthcare experiences are like. So we decided to include this so we start to see a picture, and also noting that we have a gap here. Lisa Crowan, who is a co-author on this report, is a co-author in many of the papers that we pull from for this report, and also a lead investigator out of Kaiser. Okay, and then throughout my presentation, I'm going to make comparisons to a few groups. One of the main comparisons we make is to children with special healthcare needs and children without special healthcare needs. In this context, children with special healthcare needs are defined as children who use more services than other children their age would be expected to use, and for conditions that are expected to last longer than 12 months. This designation is not specific to conditions, but most children who have qualify for being a child with special healthcare needs also have a health or behavioral health condition. So for example, from the surveys that we used, nearly all autistic children also meet the definition of being a child with special healthcare needs. All right, and then a warning before I start. I just want to let you know that these slides will be available after the presentation. I want to take time to mention this because I'm going to be presenting a lot of data and a lot of graphs on the following slides, and you may find yourself desiring to look at them in a little bit more detail or a little bit longer, but I'll do my best to point out what I think are the most salient findings, and hopefully that all makes sense. Okay, so we're going to start with overall health. So we'll start with an easy one. About 2/3 of parents of autistic children, ages 3 to 17, rated their child's health as very good or excellent. So we were able to compare this to children with special healthcare needs and found very similar ratings. However, parents of children with no special healthcare needs rated their child's health as much better. So then we asked, when they were asked about oral health, we see a bit of a different picture. Just over half of parents of autistic children reported that their child's teeth were in very good or excellent condition. And oral health appeared worse in autistic children than it did in other children, where nearly 80% of parents of children with no special healthcare needs reported that their child had excellent or very good oral health. When we look more at the impact of a child's conditions, we see that 1/3 of parents of autistic children reported that their child's health conditions or problem usually or always impacted their ability to do things other children their age can do. So this is in pretty stark comparison to children with special healthcare needs, where almost half report that their child either doesn't have a health condition or it never impacts them. And I just want to remind you that a special healthcare need is related to the amount of healthcare that a child uses or needs, and may or may not be related to a health or behavioral condition. Another dimension of health is the presence of co-occurring conditions. So here we're examining the most prevalent co-occurring conditions in children. When parents were asked about whether their child had certain health conditions, autistic children had higher rates of every single condition except for asthma, which is third from the bottom down there. So the most common conditions were learning disability and developmental delay. And then we also see that half of children had behavioral or conduct problems or speech and language disorder. And certain conditions varied in prevalence by race and ethnicity in autistic children. So ADHD and anxiety, which are the bottom left and top right graphs here, were the most common in white non-Hispanic children. Asthma and developmental delay, which are in the opposite corners, the upper left and the bottom right, are the most common in Black non-Hispanic children. And then the two graphs in the middle, learning disabilities and speech or language disorders, are more common in Black and Hispanic children than they are in other children. We were also able to look at co-occurring conditions in autistic transition age youth. And in this study, that's defined as children and adults ages 15 to 25. This is one of those Kaiser Permanente previously published findings, a paper by Davignon et al. This particular study found that most psychiatric conditions were more common in autistic transition age youth than in their peers, including anxiety, depression, and bipolar. And they found that most medical conditions were also more common in autistic youth. The exception is the third from the top up there, musculoskeletal conditions. Now we can take a look at co-occurring conditions in adults. This work by Crowan et al., also from Kaiser records, examines adults ages 18 and over. So we see the same pattern that we saw in children and those transition age youth. The conditions are more common in autistic adults than they are in peers without autism. The most common conditions at the top are stomach or intestinal disease, and obesity and anxiety. But I also want to point out the higher rates of hypertension, which is a potential marker for physical health care, and then epilepsy, which is a much higher rate than normal. On next to health services. Understanding how people interact with their healthcare and how their healthcare system provides for them can help us to improve outcomes. Okay, so we'll start with parent report of healthcare visits. 95% of children had a visit with a medical provider in the past year. That was similar to children with special healthcare needs, but more than children with no special healthcare needs, which reported 70%. A notable finding is that autistic children went to the doctor a lot more. So the average number of visits to a healthcare provider was 29 for autistic children compared to 9 for children with special healthcare needs. Although visits to a healthcare provider were common, they were less common in Hispanic children. And we found that only 80% of Hispanic children had reported visiting a healthcare provider in the past year. So a visit to a doctor is not the only or maybe the best marker of healthcare. We can also look at qualities of care to see what differences might exist there. Here we're looking at the presence of a usual source of care and the presence of a personal doctor or nurse. A usual source of care is someone the parent reports going to when they encounter a health need, and a personal doctor or nurse is someone that knows the child and knows their health history well. White non-Hispanic children were the most likely to have a usual source of care and to have a personal doctor or nurse, along with children of other or multiple races who were not Hispanic. Receipt of specialty care is another important consideration, and here we're looking at mental health care. Nearly half of autistic children received treatment or counseling from a mental health professional in the past year. And that was a percentage that was much larger than children with special healthcare needs and children with no special healthcare needs. This also varied by age. So just over half of older children ages 12 to 17 received mental health care versus about a third of younger children receiving mental health care. And then again, we note differences by race and ethnicity, where Hispanic children are the least likely to receive this type of care. About a third report it, compared to about 50% of all other children. So another aspect of healthcare is expenditures, both out-of-pocket and insurance expenditures. The average total expenditures for all healthcare in the past year was the highest in the group of autistic children. It was at $13,000 per year. Out-of-pocket expenditures, which are the expenditures the family pays themselves, so that might include co-pays, they were also higher in the autistic group than they were in other children. So the way we interact with the healthcare system changes over the life course. And possibly one of the biggest changes is when we change from pediatric to adult care. This process is formally known as healthcare transition, and reports of transition services in children with autism are very low. So taken together, all of the components of this graph make up the transition process. Some of the components are more often met, like at the top we see that 3/4 of autistic children worked with their provider to make positive health choices, but others are very rarely met. Down at the bottom, we see fewer than 1/3 and as little as 1/4 of children work with their provider to understand the changes that happen at age 18, create a written plan to transition their health, and discuss the switch to an adult provider. I also want to point out this highlighted, the second from the top bar. So this is the provider working with the child to gain health skills. 20% fewer children with autism have their parent report this than children with special healthcare needs. And I think that's a really interesting finding because we've seen so far that autistic children have pretty intense healthcare needs in comparison to this group. And so if anybody is going to need assistance to gain skills to advocate for their health, it's going to be autistic children. We also get a unique look at preventive health services. This comes from a Kaiser study from Zerbo et al. So they were able to look at preventive services that adults may be receiving through their healthcare provider. And they found that autistic adults are actually more likely to get some preventive services, including flu vaccines and cholesterol and diabetes screenings, than their peers. We saw a little bit earlier that autistic children see the doctor more often, so it's possible that this is part of a similar finding. However, when we look down at the bottom at preventive services in women, we see this lower rate of cervical cancer screening in autistic women than in their peers. This is problematic as autistic women are a very understudied population, and specific information and attention paid to the services they receive and how they interact with health systems is certainly warranted. All right, now we turn to inpatient hospitalizations. We looked at autistic children and adults, and here you see both of these graphs show the average length of stay and the average cost per day of inpatient stays. On the left, we're looking at children. So the length of stay was shorter in autistic children than it was in a comparison group of children with other mental disabilities. NBND stands for mental, behavioral, and developmental disabilities. So while their length of stay was shorter, the cost per day was higher by about $500. On the right, when we look at autistic adults, we actually see the opposite. So the length of stay was longer in autistic adults by 2 days, but the cost per day was lower by about $1,000. This might have to do with the types of conditions that children versus adults are admitted for. And here are those conditions. On the left, again, we have children, and on the right are adults. So these graphs show the most common condition that autistic children and adults are treated for. This is the primary condition, and ostensibly that's the reason for their stay. So for both groups, mood disorders were the most common. However, we do see some differences between these groups. In children, epilepsy is much more common than it is in adults. And in adults, we see injuries, and schizophrenia and septicemia are much more common. So in both children and adults, many of these conditions are something that are referred to as ambulatory care sensitive conditions. This is the idea that these are conditions that should not lead somebody to hospitalization if their condition is being adequately treated in primary care. But the high rates of these conditions is likely a marker that, especially in children, they're not receiving comprehensive care for all of their conditions within their primary care setting. All right, so next we're going to look at medications. So prescription use was really common in children, autistic children, as well as other children with special healthcare needs. Nearly 3/4 of autistic children filled a prescription in the past year. Here we look at the most common classes of medications. So the most common was central nervous system stimulants, CNS stimulants, followed by antimicrobials and antidepressants. So CNS stimulants are used in conditions like ADHD, and they include prescriptions such as amphetamine, dextroamphetamine, and methylphenidate. And antimicrobials include things like antibiotics, antivirals, and antifungals. The only medication that was more common in children with special healthcare needs than it was in autistic children is medications for respiratory or allergy. I will point out that asthma is a very common condition in children with special healthcare needs, and that could help explain that finding. So some medications were more common in older autistic children than in younger ones. This was true for medications that parents reported were used for autism. That was the wording of the survey question. 1/3 of children ages 12 to 17 were taking medication for this purpose, compared to 22% of younger children. And then we also saw some differences by race in this type of medication use. So on the right, we see that white and Black autistic children were more likely to use medication for autism than were other children. We see a similar picture here for medication that was taken for difficulties with emotion, concentration, and behavior. So half of older children ages 12 to 17 with autism took a medication for difficulties with emotion, concentration, or behavior, and 30% of younger children did. And then we see a somewhat similar pattern by race and ethnicity, with nearly half of white autistic children taking medication for this purpose, while only 1/4 of Hispanic children were doing the same. So we see some differences in medication use, and we can also look at medication expenditures. So autistic children had an average yearly expenditure of $2,700, almost twice as much as children with special healthcare needs. And then their out-of-pocket expenditures were $158 per year. Again, the out-of-pocket expenditures are those expenses that the family pays themselves, including copays. I also have a little data to share about adults. This is another Kaiser study, this by Zerbo et al. So they found that 80% of adults with autism, they were looking at everyone ages 18 and older, had at least one prescription in a year. And they found that rate was similar to adults with ADHD, but more than adults in the general population, where 62% had a prescription filled. So the most common medications are listed here. They were psychotherapeutic agents, anti-infectives, and medications for respiratory or allergy needs. Psychotherapeutics were a lot more common in autistic adults than they were in the comparison groups. The difference in other medications at the bottom half of this graph were smaller, but autistic adults were the least likely to have filled an anti-infective or an analgesic or pain medication, and were the most likely to have filled a cardiovascular medication. This particular finding matches the finding that autistic adults have higher rates of hypertension than their peers. So our next topic is insurance. For many people, insurance is the gateway to healthcare, and it also dictates what type of care we can receive and from whom. It's also an important place for intervention because policies can dictate many insurance decisions. So most children had insurance at the time of the survey, and almost all were continuously insured over the past 12 months. But we did find that public insurance was more common in autistic children than it was in other children. Over half, 56% of children had either Medicaid or CHIP, some kind of public health insurance. And we also found that younger children were more likely to have public insurance than older autistic children. So while nearly all children were covered by insurance, not all reported adequate insurance coverage. About Only about half of parents of autistic children reported that their child's insurance always covered the services they needed. That's the graph seen on the left here. In the middle, about 2/3 reported that their child could always see the providers they needed. But on the right, we see that only 44% reported that their insurance covered mental and behavioral health needs. Mental and behavioral health needs were largely a problem for all children, but these other areas of access to care seemed worse for autistic children than for their peers. So insurance makes care accessible, but plans do vary in how much they cover. On the left, we see that 1/3 of families of autistic children reported problems paying for their child's health care in the past 12 months. And on the right, we see that 1/5 of parents avoided changing jobs because they had concerns of losing their health insurance for their child. And these problems, again, seemed more common in families with autistic children than in families of other children. We can also look at the primary expected payer for hospitalizations, which is a slightly different population here. On the left, we're looking at children, and on the right is adults again. So in children, we see that about half had a primary expected payer of Medicaid, and that's very similar to children with other mental disabilities. On the right, when we look at adults, we see that 2/3 of adults had a primary expected payer for their hospitalization of public health insurance, largely similar to their peers with mental disabilities, although the portion who reported Medicare was smaller for autistic adults than it was for their peers. And then finally, I have some findings related to accessing services. So this includes components of care and care models that improve care quality, like care coordination and referrals, and also the medical home. And then I'm also going to discuss some unmet healthcare needs as reported. All right. So as we've seen so far, autistic children use a lot of services. Integration of these services makes healthcare easier, and it also makes it safer. One way to connect services is through care coordination. On the left, we see that parents whose autistic children used more than one health care service in the past 12 months, 28% reported that they had help coordinating the care between these providers. This was a very similar rate to other children with special healthcare needs, but larger than children with no special healthcare needs. This difference might be due to care complexity and the relationship that the families have developed with providers because of ongoing service needs. On the right, we see that of these same parents, those who saw more than one provider, nearly 1/3 of parents of autistic children reported that they needed more help in coordinating their care, which was double the rate of children with special healthcare needs. Again, the need for coordinating care also varied by race and ethnicity, with many more parents of Black autistic children reporting that they needed help coordinating their care. And many parents spent a chunk of change coordinating care for their child. So more than 1 in 4 parents spent at least an hour coordinating care weekly. While you can see in the bottom 2 rows, the majority of parents of children with special healthcare needs and children with no special healthcare needs reported that their child did not need weekly care. So the care burden is much different here. All right, and then so referrals are a way for primary care providers to identify other providers that a child might need to see. It's also sometimes a requirement by insurance plans for reimbursement of specialty services. So of children who reported a need for a referral, 40% of parents reported a need for a referral. And we see a similar story to care coordination, where of those that were seeing providers, multiple providers, 1/3 reported that they had problems getting the referrals they needed. And again, this was a higher rate than children with special healthcare needs and children with no special healthcare needs. And then another concept that we investigated here was the patient-centered medical home. This is a model of healthcare that aims to provide comprehensive, coordinated care with the overall goal of reducing complexity, which we've seen here is definitely at play, and improving healthcare quality. So the medical home helps coordinate across multiple services and multiple systems that provide care. But only a third of autistic children receive care within a medical home. Much fewer than children with special healthcare needs, and the 50% of children with no special healthcare needs who receive care this way. There's also variation by race and ethnicity, with white autistic children being the most likely to have care through a medical home, and only about a fifth of Black children are receiving care through a medical home. So with this reporting need for the low care or high needs for coordination and referrals and low use of medical home, it's probably unsurprising that parents are frustrated in their efforts to get services. More than half of parents of autistic children reported that in the past 12 months, they've been at least somewhat frustrated in their efforts to get services. And this frustration was more common in parents of autistic children than in parents of children with special healthcare needs or no special healthcare needs. Further, parents of younger children were more likely to report frustration than parents of older children. It's possible to navigate all this complex health landscape, and they haven't built the resources yet to deal with navigating all that. Right. Another dimension of service is unmet need for services. So 11% of parents of autistic children reported that their child did not receive some of the care they needed in the past 12 months. Of those parents, the most common reported unmet need was mental health services, and half of parents reported that as an unmet need. Dental care was also a very commonly reported unmet need, and that particular need spanned across all these comparison groups, and children with special healthcare needs and children with no special healthcare needs also reported a high need for dental health care. When we examined the reasons that children had unmet needs, the most common reasons were difficulty getting appointments and issues related to cost. And 50% of parents reported both of those as barriers to care. So not only are there structural barriers to care, but there's also personal and personnel barriers. This is a study by Zerbo et al. That interviewed physicians that work at Kaiser about their tools and skills to treat autistic adult patients. 3/4 of providers rated their knowledge and skills for providing care to autistic patients as poor or fair. They also noted a lack of support for the provider and the patient to receive adequate care. So the top 2 lines of this graph show that only 1/4 reported that their patient or their patient's caregiver had enough support to partner with providers, and even fewer in the third bar reported that they had adequate tools to accommodate autistic patients in their own practices. So I want to revisit some of these findings and just highlight a few things that overlap across these different topics. So healthcare transition. I discussed the low rates of preparation for the switch from pediatric to adult care. Care is fundamentally different in childhood than it is in adulthood, as the responsibility for care falls upon the patient and not the provider or the parent once they're an adult care model. Transition often also includes changes to providers who treat adults and maybe a host of new specialty providers. But we saw that fewer than 1/3 of autistic youth work with their provider to understand these changes, create a written plan for transition, or discuss the transition to a different provider. But that doesn't capture the whole picture, because who do these children transition to? I just shared these results a couple slides ago on low provider knowledge and inadequate support for autistic adult patients. And this is a commonly cited problem, and the solution is very complicated. So none of the physicians in this particular survey received formal training in screening or diagnosis for autism. And again, 77% rated their knowledge and skills for providing care as poor or fair. And this was even worse in some of the disciplines that they looked at. So 88% of OBGYN providers reported that their knowledge was poor or fair. And perhaps this makes sense, as we saw earlier, the very low rates of preventive services for women, autistic women. All right, so I'm also going to highlight a few gaps in primary care. We saw a little evidence that primary care is not serving autistic patients in a comprehensive manner. We saw unmet needs for mental health services, low rates of cervical cancer screenings for women, and then we saw that emergency department use and inpatient hospitalization were not different. The rates were not different between autistic and non-autistic people, but we did see that the most common reasons for hospitalization in autistic children and adults were for conditions that could be managed in primary care, things that should not land a person in emergency care. So mood disorders, epilepsy, and asthma are some of those. So I also need to highlight the racial and ethnic disparities that persisted across all 5 chapters of this report. ADHD and anxiety were more common in white non-Hispanic children than they were in children of any other race, while asthma and developmental delay were the most common in Black and non-Hispanic children. Racial and ethnic minority autistic youth are more often misdiagnosed and underdiagnosed than white youth, and the behaviors associated with autism may be misinterpreted in these populations, and this is a common and persistent problem. We also saw that Black and Hispanic children were the least connected to comprehensive care, with lower reports of usual sources of care and personal doctors or nurses. And then we saw that half of families of Black autistic children had trouble paying for their medical care, compared to a quarter to a third of other families. And finally, parents of Black autistic children were the most likely to report that they needed more help. So they needed help coordinating care and they needed help accessing referrals. All right, so I reviewed a lot of results in this presentation, and I want to just take a few minutes to summarize them with an eye towards moving forward. First, health services and interventions can positively influence health, just as a lack of these can lead to poor health. So we highlighted the need for improved health and healthcare in autistic people of all ages. We highlighted racial and ethnic disparities that are associated with worse health and poorer services in autistic children. And we saw a general trend that autistic people receive more services and spend more on healthcare and use more medications than their peers. We also saw complex healthcare needs, and we know that these make comprehensive care both more important and more difficult for autistic people. Barriers to this type of care can cause worse health, as we saw compared to peers. And providing more appropriate care and reducing these barriers can lead to better health and can lead to less usage of emergency healthcare and inpatient hospitalizations. So as always, this work highlights areas for future inquiry and need for attention. With this in mind, I end with a few recommendations for research moving forward. In general, more work is needed to understand why health and health services are worse for people on the spectrum, and determine how to improve these services, with the overall goal always of improving health and quality of life. So first, I want to say that we need to embrace this idea that all types of health are important. So not just physical health, but dental care, vision care, specialty care, and mental health care, as was repeatedly pointed out in our findings. These are all important considerations in health, and they all impact life and quality of life. And considering only physical health and health conditions is not enough, especially in autistic people, where we saw high rates of medication use that point to the need for behavioral supports and systems that support the provision of this type of service. The lack of transition services was also especially problematic, given the lifelong nature of autism and that the experiences early in life impact outcomes later in life. So second, we need to focus more on coordinated care to improve health. Healthcare is complex. Take, for example, in chapter 1, I showed you some reports of poor dental health. Reasons for poor dental health could be influenced by many factors: lack of insurance coverage, need for behavioral supports for successful office visits and for daily dental hygiene, dietary issues related to dental health, or a lack of accommodations at the dental office. So if these all impact dental health, a truly comprehensive approach to healthcare would consider all of these in provision. So third, we have to do a better job of addressing the persistent racial and ethnic disparities that pop up over and over. Acknowledging these disparities is only the first step to addressing them. We need to do much more work to reduce them. Another area here that is applicable is the reliance of public health insurance that is especially prevalent among underserved and underrepresented groups. Suggests that research focused in these systems could be an area of emphasis for improving outcomes. So fourth, I would be remiss to not mention the assessing the impact of our current pandemic on autistic people. So I think that the pandemic highlights the shortcomings in the provision of healthcare to high risk and hard to serve populations, including autistic people. The inability to receive services timely and accessibly impacts care and may exacerbate health conditions. More involvement with the medical system also increases the risk of exposure to COVID. Right now, we have a unique opportunity to examine the impacts of this systems-wide disruption on such high-risk populations. And then I would finally like to end by saying that we need more data. While this report examines outcomes from multiple data sources and across the life course, there is an obvious emphasis on child health. This is not by desire, but by demand. So comprehensive data on adult health and healthcare is largely unavailable at the national level. The data that we do have and that we have presented comes from specific healthcare systems or segments. And as a result, we don't have adequate information on nationally representative data to explore the needs and outcomes of adults. I would like to acknowledge and thank profusely my co-authors on this report, Anne Rue, Christy Anderson, and Lindsay Shea, who I work with at the AJ Drexel Autism Institute, Lisa Crowan from Kaiser, Alice Kuo from UCLA, and Paul Shattuck from Mathematica. I would also like to acknowledge some contributors. So Andrea Avanto, who did the graphic design for our report. It looks amazing. And Paul Cirillo, who provided support for editing. And then I would also like to announce my funding acknowledgements. So the Autism Transition Research Project funds our research into many aspects of life for transition age autistic youth and adults. We are also grateful for new funding from the ARP, the Autism Intervention Research Network on Physical Health. This new funding will help propel our findings from the ATRP forward. It's a new source for us, and we're still developing our trajectory in this work in this area and working within the health services and systems node of ARP. And the full report is available online for those of you interested at our website, which is drexel.edu/autismoutcomes/NAIR-health. And you can also scan this code to take you directly there. Thank you.
Wow, thank you very much for the presentation, Jessica, but also for your work in this area. So we now have time for questions and answers. I'll start with some of the questions that were already submitted in the chat, and I can read them aloud, but please feel free to type additional questions in the chat box, and I'll also read those for Jessica, for the presenter as well. And finally, I will post a link for the feedback survey in the chat also. So I will start, Jessica, with a question from Peggy. They're asking if anyone knows the status of the IACC, and will there be a concerted notice of soliciting family members and autistic persons, both youth and adults, including more racial and ethnic diversity of the council, and how this council will better support policy for the life course of those with autism?
Yeah, that's a great question. I think that's a question that keeps coming up. It seems to be popping up. IACC has been a bit quiet. I have heard that they are definitely still working on convening their next membership council for their next session. They were refunded. I don't personally know anything about the status, except to know that they are reconvening. I hope that they continue to increase the presence of self-advocates and family members on their board, which I think is a priority of theirs. I do not know anything about their priorities as it relates to racial and ethnic diversity, but I hope to see that as a priority for them as well. And also gender diversity.
And then we also had a couple of comments from Dana, who is actually one of our, on our ARRB board, Artistic Researcher Review Board, which has been insanely helpful with the AARP. So they were asking some questions about interoceptive issues, make reporting so difficult. So they were saying that they think it would not be a stretch that parents use docs more because it's the only way to know what's happening with someone who struggles to report. So like verbal or non-speaking. And then there also was a comment from Dana that autistic women are massively understudied because they're often not believed, they're misdiagnosed or underdiagnosed. And this leads to trauma with the OBGYN care and they begin avoiding it.
Yeah, I think that's a great comment. I agree wholeheartedly that that's a very understudied area and that there's probably a lot of intricacies to why that's true and why women may not be seeking the care that they should be seeking, especially in regards to preventive care and emergent health conditions. I really know very little about that area, and I don't know that I'm the only researcher that would have to claim they know very little, unfortunately. But I really do think it's an important area of inquiry, and I would not be surprised to hear that researchers at ARP are looking into that.
Exactly, you're very correct. We have the gender, sexuality, and reproductive health node that is actually the lead is Lisa Crowan, one of the co-authors on the NAIR. Yes, definitely.
And I think the first question or first point was about the reason that parents may go to a healthcare provider to help understand their child. I really, I don't have much introspection on that point, but I do think it's an important point. The way that a parent interacts with their child, and then the way that the parent and the child have an opportunity to interact with the provider is important. Increasingly, it's seen as important that the child has the opportunity to interact with the provider on their own without the presence of the parent, to help build healthcare skills and then be able to talk about sensitive topics as well. I unfortunately think that that's probably going to be something that happens less with autistic children than with other children, just because provider relationships with children may be different for autistic children based on communication impairments or something related. And I think that that's an important thing that needs to be overcome because it's still an important aspect of healthcare. And as we talked about today, it's a necessary thing for all people, not just people who the doctor can communicate with.
Okay, thank you for your feedback on that. Jill is asking if there are higher rates of hypertension in autistic adults, are the higher rates of hypertension in autistic adults controlled for obesity?
I don't know the answer to that question off the top of my head. I believe that so that was a Kaiser study, and they did control for many factors, and I would not be surprised if obesity was one of the factors, because we did see higher rates of obesity in autistic adults as well in that same graph. But I don't know for sure. The citations for those papers are available in the report, but I can also share those to you if you want to add them to the website when you post the slides.
Okay, perfect. Thank you very much. There were a couple of newer questions. Let's see. Have you found any data on autistic persons who also identify as transgender accessing healthcare?
No. So as we mentioned, there's really limited data on autistic adults. I think that the compounding issue here is the intersectionality between autism and gender identity, which is also an understudied area in general, but also in medical health. There could be studies that address this. I know there's no national level data that addresses this, which is generally the type of data we use to present these findings. I also wouldn't be surprised if that was an area of inquiry for one of the ARP nodes, because
Yep.
it could fit within that, but I don't know of any research into that.
Yep, it definitely fits within the gender, sexuality, and reproductive health node. These are an anonymous attendee asked two really good questions. They're asking, what is a medical home and what does effective coordinated care practically look like?
Yeah, that's a great question. So a medical home is a concept of a way of providing care that makes it more comprehensive. So it's not a physical place. It's the same provider that a child may go to, but the provider makes efforts to coordinate with other providers on their child's care and their care needs. There's a centralized medical record, so the records of the child's visits across providers are available for all providers. And the care is family-centered, so the provider includes the family in decisions about care and listens to their voice on what they want to do with their child's care. What does it look like? What does care coordination look like in practice is a complicated question. So integrated care, there's levels of care integration, and I guess sort of the lowest level is care coordination. So that just means that you have separate providers that decide to communicate with each other about your care. The reason it's complicated is because it takes time to coordinate care. So your provider has to take time, or somebody at your provider's office, to speak to another provider. That may or may not be an activity that's reimbursed by your insurance. So they may not be able to bill for their time of coordinating your care. So there are barriers to care coordination, but there are providers that do coordinate care in that way. But coordinating care just allows all of your providers to know what's going on. So you get better care, you have to repeat yourself less, and you have more safety in your care because, maybe you have an allergy that's a medical allergy that one of your providers knows about. But if they didn't tell the other provider, there could be no overlap in that knowledge. And that's just one example, but it's a good idea, but it's hard in practice.
Mm-hmm. And we will likely hear more about both care coordination and the medical home model in future ARP webinars. We're running short on time. There were two other questions. One was asking about any stats on employment losses for the mother of autistic children. And we also put the link to the full publication into the chat. And I know you also shared it on the slides as well. And then also there was a question about are there models of best practice for transition to adult health care?
I'll start with the last one. So there are models of care for transition. There are national and state governing bodies that say how healthcare transition should look. It's not, practices can choose to do it in an individualized manner, but they don't have to, nor probably should they. There's bodies out there that tell providers the best way to provide this type of care. So there is some oversight's not the right word, but some suggestion of how this should happen. I don't remember the first question.
No worries. You have gone through quite a few of them, 12 in total. It was asking about statistics related to employment loss for mothers. But thankfully, we've been able to provide the link to the report. So there might be some more information in there because it looks like we are at time. So I put a link in the chat to to a survey for attendees to please fill out to provide us some feedback. But I just wanted to take the very last minute to thank everyone for attending the webinar and to thank Jessica very, very much for taking the time to provide us more information about the National Autism Indicators Report. It's been very interesting hearing about it. As I said, the webinar is being recorded and will be archived on the AARP website. Please take a few moments to complete our survey, and thank you all very much for attending.
Thank you.
Thank you, Jessica. Have a good rest of your day.